Types of jaundice. It can be prehepatic jaundice or intrahepatic jaundice or posthepatic jaundice. Prehepatic jaundice disruption happens before bilirubin has been transported from the blood to the liver, and it is caused in conditions like sickle cell anemia and hemolytic anemias. Intrahepatic or hepatocellular jaundice is when disruption happens within the liver, and it is caused by conditions such as Gilbert syndrome and liver cirrhosis. Posthepatic jaundice or obstructive jaundice, the disruption prevents the bile and the bilirubin inside it from draining out of the gallbladder and into the gastrointestinal tract. It is caused by gallstones or tumors in the gallbladder. Classification of jaundice according to the type of bilirubin increased in plasma. It can be predominantly unconjugated hyperbilirubinemia or predominantly conjugated hyperbilirubinemia or a mixed version of conjugated and unconjugated hyperbilirubinemia. Indirect or unconjugated bilirubin is more than 85% of total, then it is predominantly unconjugated hyperbilirubinemia, and the causes are hemolysis, resorption of a large hematoma, ineffective erythropoiesis, congenital diseases like Gilbert syndrome, Crigler-Najjar syndrome. Predominantly conjugated hyperbilirubinemia is direct or conjugated bilirubin is more than the 50% of the total bilirubin, and the causes are hepatitis, cirrhosis, cholestasis, anabolic steroids usage, oral contraceptives usage, toxins, and congenital syndromes like Dubin-Johnson syndrome and Rotor syndrome. Mixed when it is conjugated hyperbilirubinemia or conjugated bilirubin is 20 to 50% of the total bilirubin, and the causes are alcoholic hepatitis and viral hepatitis. Classification of jaundice can also be done according to the site of the disease, that is prehepatic or hemolytic, hepatic or hepatocellular, post-hepatic or obstructive. Obstructive causes includes tumors and gallstones. Hepatocellular includes viral hepatitis, toxic hepatitis, Gilbert syndrome and Crigler-Najjar syndrome. Prehepatic or hemolytic includes hemolysis or abnormal RBCs, thalassemias and hemoglobinopathy. Differential diagnosis of jaundice. Based on the mechanism of the bilirubin, hemolysis will lead to excessive production in prehepatic jaundice. Deficient uptake, conjugation or excretion by hepatocyte it causes the raised bilirubin in hepatocellular jaundice. Deficient excretion due to obstruction of the biliary tract is seen in obstructive jaundice. Mainly unconjugated serum bilirubin will increase in prehepatic jaundice. Conjugated more than 50% bilirubin rises in obstructive jaundice, and it will be mixed in hepatocellular jaundice. Urine bilirubin is absent in prehepatic jaundice and present in hepatocellular and obstructive jaundice. Urine urobilinogen will be increased in prehepatic jaundice and decreased or absent in obstructive jaundice. Prothrombin time will be normal in prehepatic jaundice. It will be abnormal in hepatocellular and obstructive jaundice. It can be corrected with vitamin K in obstructive jaundice, and it cannot be corrected with vitamin K in hepatocellular jaundice. Features of hemolysis and blood smear like reticulocytosis, low haptoglobin, low hemoglobin is seen in prehepatic jaundice. There will be marked rise in ALT and AST levels in hepatocellular jaundice. Marked rise of serum ALP more than the 3 times the normal is seen in obstructive jaundice. Differences between the types of jaundice. In hemolytic jaundice, persons will be younger age, hepatic, young or middle age, older age group, obstructive jaundice. No abdominal pain in hemolytic jaundice. It is present in obstructive jaundice, and it may or may not be present in hepatic jaundice. Color of the urine is dark yellow in obstructive jaundice, and color of the stool is clay colored in obstructive jaundice. And there will be pruritus in the obstructive jaundice. The icterus will be lemon yellow in hemolytic jaundice, yellow in hepatic jaundice, and greenish or dark yellow in obstructive jaundice. Indirect bilirubin more in hemolytic jaundice, indirect or direct more in hepatic cellular jaundice, and direct more in obstructive jaundice. ALT, AST. It is elevated in hemolytic jaundice, markedly elevated in hepatic jaundice, normal or elevated in obstructive jaundice. Alkaline phosphatase will be elevated in obstructive jaundice, and serum proteins will be decreased in hepatocellular jaundice and normal in hemolytic and obstructive jaundice. Evaluation of the cholestasis. First, we have to see whether jaundice is present or not, whether there is pruritus or not, and the urine how it is, dark or normal, how are they. whether they are clay stools or normal, whether elevated bilirubins or bile acids is seen. Through history and examination, we have to advise basic investigations like LFTs, albumin, coagulation profile, fasting blood sugar, lipid profile, etc. With the help of imaging, you can advise CT or MRCP ultrasounds. If the reports show predominant elevated cholestatic enzymes, consider biliary disorder. And if transaminase levels are elevated, hepatocellular disorder, and mixed liver enzymes derangement, then it can be any cause. Biliary obstruction, advise ERCP or PTC surgery and treat the complications, infection or cholangitis, nutritional support, vitamin supplementation, and hepatic decompensation. If there is no biliary obstruction, perform the liver screen, treat the underlying cause, and consider liver biopsy prior to this. Treat the complications and treat the pruritus using antihistamines. Consider the role of liver transplantation as the final step.